Welcome to the Causes or Cures podcast, your gateway to understanding health and groundbreaking medical research in a fun and easy to understand way. With Dr. Eeks as your host, join us as we sit down with the world's leading doctors and scientists to unravel the mysteries of health. From practical tips on well-being to the latest breakthroughs in medical research, we cover it all. Don't forget to subscribe. Now, let's ignite our curiosity and together dive into today's episode.
Hello, everybody, and welcome to the Causes or Cures podcast. I'm Dr. Eeks, your host, and thank you so much for joining in. So, for this episode, we're talking about health and wealth, health and money. There's a lot of focus right now on longevity, as I'm sure a lot of you know. And if you listen to my podcast or scroll on back, you'll find a lot of episodes about longevity. There's biohackers, there's supplements, there's lifestyle hacks. But how much does the number in your bank account matter when it comes to how long you live? I think we all intuitively know that it matters somewhat. But what happens when you compare those money relationships between the US and Europe? My guest today is Dr. Irene Papanicolas, and she is professor of health services, policy, and practice at Brown University. And she and her team published a study in the New England Journal of Medicine that examined the relationship between wealth and mortality, or death, across the US and Europe. And her team looked at data from more than 73,000 adults, comparing not just within countries, but also between them, including how wealthy Americans fare against their European counterparts. So in the episode, we'll talk about how she defined wealth, what the key results were, what the so-called survivor effect means, and you should know that in case you come across it in future studies or, you hear media people talking about it, you'll know what it is. And why even wealthy Americans may be dying earlier than poorer Europeans. Yeah. We'll also explore whether diet, the U.S. food environment, culture, or lack of healthcare access might explain these differences, or if something else is doing it, and what evidence-based interventions could make the biggest impact going forward. So this one really gets at the heart of longevity and inequality, which I know is kind of not a popular word with a lot of people, but it does matter. It still matters in public health. And what it takes to live longer, healthier lives, which I think is something we all want to do, or most of us want to do it. I mean, I don't know. Some may want to get out of here earlier, but that's a different podcast. All right, everybody. So give me a few seconds here while we connect to Dr. Irene. All right, everyone, we are connecting with Dr. Irene Papanicolas, and we're going to talk about mortality and wealth and lifespan, all the good stuff. But Irene, thanks so much for joining in, and I'm excited to chat with you about this topic. But first, do you mind telling our listeners a little bit about yourself and the work you do?
Sure. Thanks for having me. It's a pleasure to talk about the work. So I'm a professor of health policy at the Brown School of Public Health, and a lot of my work focuses on comparing the U.S. to other high-income countries and seeing what we can learn as a healthcare system about what we can do better to serve the population. And so this is a piece of work kind of that fits in with that broader portfolio.
Okay, so were you always interested in wealth and mortality and, because lifespan is in the news, right? Yeah.
Yeah, I've been interested in really health outcomes and kind of what are all the different factors that influence them. My starting point kind of coming at this has been really the health care system. And a lot of my work has started out with looking at differences in how the health system is financed, how care is delivered, and trying to understand what that means for the outcomes that people get. But obviously, we know that that your position in society, where you sit on the socioeconomic spectrum, matters for all these things. And so it's kind of impossible to do this work without thinking about the role of things like wealth, income, and education. So yeah, yeah, I guess you could say I've always been interested in this question, but have come to it kind of through different lenses.
Okay, and we're going to hear more about your theories on why our lifespan seems to be declining. So for your study, you looked at the one we're currently talking about, 73,000 adults. Could you just tell our listeners a little bit, give them the basics and how you did your study?
Yeah, so we used two surveys. These are surveys. This is a survey in the US called the Health and Retirement Survey, which is a survey that started in 1992. It's a cohort study, so it looks at older Americans, and the motivation behind this study is to understand their health as they age and retire. So it collects a lot of variables related to their health and their wealth, income, assets. So as this study has been rolled out over time, many other countries have created what they call sister surveys. And so there is one that exists in Europe called the Survey of Health, Aging, and Retirement in Europe, which has many of the same questions. So it allows us to do some nice comparisons between the two. And so we took these two surveys and some of the variables that were similar, which allowed us to compute amongst approximately 74,000 adults aged 50 to 85 in the US and Europe, their wealth, and follow, in this case, their mortality over time. And what we were interested in is how does your relative wealth position, so where you are kind of in the wealth distribution in your country, relate to how long you live. And so we took those variables and kind of explored that relationship in this paper.
So for wealth, did you have like high brackets, low? How did you define that or divide them into brackets?
Yeah, so we took quartiles within each country. And so what we were interested in is if you took everybody and you kind of ranked them from the poorest to the wealthiest in society and you divided them into four equal groups, based on that, how do you fare if you're in these different groups? And so the absolute wealth, like your nominal wealth, might be different in the U.S. versus Switzerland, or versus Portugal. But what matters in this study is where you are in relation to others in your country.
Okay, that makes sense. And for wealth, is it like income, assets, just to give people an idea? Okay.
Yes, it's income, assets. We also, in the main analysis, we don't include housing wealth, but we do adjust for it in a sensitivity analysis. So we're trying to take into account all of not just what you're earning, but all of your assets.
Investments.
Investments, yeah. Exactly, which speak more to potentially the amount of resources that you have, particularly as you retire, to be able to afford your healthcare needs, your lifestyle needs, and we can get into why we think that matters.
Absolutely. So can you tell us a little bit about some of like your key results that our listeners would be interested in?
Yes, I think there's really kind of three big results. First is your position, your wealth matters for your health. That's true everywhere, but it's more true in the US. So that's the second finding, that we see much bigger gaps in the US across these groups than we do in Europe. So particularly amongst the top three wealth quartiles, we see that these are much more clustered together in terms of survival in other European countries than they are in the US. In the US, every wealth quartile has a distinct advantage in mortality, so that the wealthiest live the longest and the poorest have the lowest survival. But every step up, you see this increase in survival, which you don't see in Europe. It's much more clustered together. You only see a difference really for the poorest Europeans. The other big difference is amongst the wealthiest in society. So we found that while the wealthiest Americans live longer than the rest of the Americans in our sample, they don't live as long as the wealthiest Europeans. And in fact, when we compare them to the Northwest Europeans, they're living at rates comparable to the poorest in Northwest Europe.
That's concerning. I guess it's good if you're in Europe, but not if you're an American like me. I'm like, huh? So I First, let's get back to the Americans, the between group differences. And I know I don't know if I know you said you were going to get the paper in front of you because I don't like to ask for specific numbers, but I was just curious, is there like a number of years difference, or is it a percentage between, like the wealthiest Americans, second wealthiest, third wealthiest in terms of, how long someone's going to live?
Yes. So,
and don't worry, because I'm like, it just came. I was like, well, what's the difference? Like,
I do have that
how
number.
fast do I need to get into the richest group? How much time do I have?
So this is kind of our main figure. So I'm just eyeballing the figure, and I can get you.
No, take your time, because I know you don't have these memorized.
But by the end of the study period, so we follow the cohort for 12 years. So at the end, the difference between the poorest and the wealthiest in terms of the percent of the cohort who survive is about 20%.
That's a lot.
Yeah, that's a lot. It's a big gap. The most comparable is in Eastern Europe.
Which countries did the best? Like, could you?
So we group our European countries into three groups. The first is North and West Europe, which is Austria, Belgium, Denmark, France, Germany, the Netherlands, Sweden, and Switzerland. And those are our best performers. Then we've got Southern Europe, which is Italy, Portugal, and Spain. And then we have Eastern Europe, which is the Czech Republic, Estonia, Hungary, Poland, and Slovenia.
And we didn't do as well even compared to those groups. Wow.
Yeah. So the closest comparator is Eastern Europe, which has a similar difference in terms of the poorest and the richest. One big difference that we see in Eastern Europe is that the top three quartiles are much closer together. So there's not really a statistically significant difference between the survival in those top three quartiles, but the poorest are distinct. So the difference in the US is that at every jump in wealth quartile, gives you this distinct gain in survival, which we don't see in Eastern Europe.
Wow. All right. So I have to ask you what are your thoughts? Why is that happening? And I guess start, like to explain, maybe to offer theories for this difference in the US and then expand out.
Yeah. So what I think about what these results tell us is that, in the US, wealth buys you health in a way that isn't true in Europe as much, because we don't see this as big of a difference between these quartiles in terms of survival. And so why is that? Well, I think if we start with kind of the gap, this has been well documented in the domestic health policy literature as well. We know there are big gaps in life expectancy across the richest and poorest Americans. We know it's also true across different demographics. We know, for example, that Black Americans have lower life expectancy than white Americans. And so there's many factors that can that probably explain this. It's not just one thing. In our paper, we're looking at wealth, and I think about it as how does wealth in this country affect your ability to live longer life? So a big one for the poorest is going to be probably healthcare coverage and healthcare access. So, do you have access to the care that you need when you get sick, to diagnose any chronic conditions that might put you at risk of, cardiovascular disease, which is the biggest killer in the U.S. So I'm thinking, do the poorest in the U.S. have the same chances of getting diagnosis, taking meds to control chronic conditions like hypertension and diabetes to prevent a heart attack? And that's just an example in cardiovascular disease. You can think about kind of the similar issues in cancer or other areas of illness that contribute that are some of the leading causes of death. So that's a big thing, I think, there, driving that inequity. And even if you have insurance, we know there's a lot, the affordability of care has become an issue for all wealth quartiles. So even if you do have health care coverage? Can you still afford the care that you need? So that's one. Another issue, I think, just has to do with the quality of life that wealth buys you. So do you live in a safe neighborhood? Do you have access to a good diet? Do you live in a place where you're free from adverse environmental effects? You have clean water, clean air. All of these things are going to matter to your longevity down the line. And we know that there's a gradient in all of these things. And so it's not just healthcare access, but it's the way that I guess these resources buy you the opportunities to good health. And that appears to be more pronounced in the US than in other countries. If we think about the wealthiest Americans, I think it becomes trickier here. These are, if we think of the top 25% of wealth in the US and who has that, they're probably, not struggling with their healthcare bills, probably live in, I don't know, safe neighborhood, but there's got to be something here systemic that's affecting all Americans that explains these results. So that really makes me wonder, what is it? What are these things? And if I go back, maybe it's not healthcare access, but definitely public health. And if we think about, the things that matter for everybody. So here, are there different environmental factors like the food that we eat, the air that we breathe? Are those things potentially different in the US than in Europe? And I think we better need to understand that. Another thing that I've been thinking could be interesting to explore here is, a lot of your position in society determines your benefits. The retirement savings you can accrue, the healthcare that you'll have in the current moment. And so does that create more stress day to day about, whether you're going to have the resources to get by? Because in a lot of these European countries, that's not the case. You have kind of a more comprehensive safety net that isn't tied to your employment as much, which might relieve kind of some of this stress, which I think you feel it, at every position in society, potentially. So these are just some of my thoughts on what might explain these differences.
Yeah. Well, it's interesting because of you would expect the wealthiest in the US just logically would do better than folks who have less than them wealth-wise in European countries. So if that's not the case, something to, and there's a lot of chatter around the chemicals and the food and all that. I don't know what your thoughts are on that, but and it's funny because you're in public health. I am too. And I was talking to someone the other day and I was like, I think people who work in public health, it takes a long time to make big changes, like the story of tobacco. Obviously we all cite that, but it took a long time because you're going up against powerful industries and people like their cigarettes, whatever. But I was thinking how much of what needs to happen maybe to get some of our chronic diseases under control is this systemic cultural shift that is super hard to pull off. Even just the way we work, right? In our commutes to work. And I don't know.
Yeah, I mean, I think I agree. Probably a lot of these systemic factors will first it's identifying what they are. I do think diet is probably something that does play a role. There are stricter regulations across the EU, and most of these countries are in the EU about, if we think around agriculture and even the chemicals that are used or what classifies as organic. This is getting out of my wheelhouse, but those things I think are worth investigating more and understanding how much is that affecting everybody's health. And but yes, like big tobacco, this will take time. But it's not going to be just food. I also think there's something to better understanding how our social safety net, helps not just the poorest Americans, but all Americans, and how much kind of this, I guess, the culture and the benefits that we have give us the security so that we can afford the opportunities to have the same opportunities to equal health and protect us from things like potentially chronic stress and other risk factors.
when you talk to somebody else, in Europe about healthcare access and, what it's like for Americans, they often they just can't believe it, and because over here, you don't have to be poor to have to go create a GoFundMe account, if you get some kind of health issue. That's just the reality. Or your insurance doesn't cover what you need, you just hear these stories and it's foreign. Like other people in other countries are like, no way, you guys have to actually do that. And you're like, yeah. Or you have to like stay at it. A lot of people, how many people stay at a job just because of healthcare, right? Like I have no idea how, I don't know if it's like go towards universal healthcare. That's where you get into, people have so many different philosophies in this country and, what it will take. But I'm curious, what do you think? Like, do you think in terms of solution? And I know like you may not have researched all the factors and all that, but I'm just curious, what do you think?
Well, actually, we had a paper that came out about a week before this one, where we looked at something called avoidable mortality across different U.S. states and high-income countries, and trends since 2009 up until 2022, to try to understand what does this look like in the U.S. and across the U.S. as compared to high-income countries. And there, too, we found some humbling results that so these are avoidable mortality or deaths that should be avoidable in the presence of good public health and timely access to high quality healthcare. And we found that across all U.S. states, with no exceptions, this has been increasing since 2009 up until 2019. And in all high income countries, I should say in the majority of high income countries, there's a couple exceptions, which are, I think, Mexico, Turkey, and there's one other, it's been decreasing. And so you just see this very different shift, which is, again, what we're seeing in part in this paper. And then we looked at the causes, like what are the causes behind this increase and decrease? And a lot of the increase in the U.S. is something called external deaths, which are drug-related deaths, homicides, suicides, increases in alcohol-related deaths, really things that a good public health system should be able to address, and also that are related to these socioeconomic determinants that we study in this other paper. So and this is pronounced across all states, but there are states that are much worse than others. And we also, though, see differences in something called the treatable mortality aspect. So this is mortality that can be prevented through high quality healthcare. And there, the biggest increase is cardiovascular disease. And so we're seeing increases in those deaths, particularly among kind of the more middle-aged population. And so here we come back to this narrative of, can you afford your hypertension medications? Are you getting diagnosed and treated for diabetes? What about obesity and the risk factors that lead to cardiovascular disease? And so here, if I think about like immediately, what are the things that we can do to try to address this problem is address these deaths, address the public health system, address the inequities that people face, that and the socioeconomic disparities that might lead people to drink or to take drugs. And these aren't necessarily, I mean, we need to fix healthcare access as well, but these are policies that have to do with, I think, broader factors in society, as well as thinking about what we do to regulate firearms and, things like taxes on alcohol, which are much higher in some of these European countries, and aren't necessarily the big costly things that we need to fix healthcare.
I feel like our whole public health system is changing right now, so I don't know what anything's going to look like in terms of addressing some of these things. Although we've really never been great at prevention, I guess. You could say that. I mean, I don't know. That's a kind of a weird statement, though, because it's like the successes you do have go unnoticed, right? Because things don't happen. So,
well, I would say actually there's certain areas of prevention that the U.S. is very good at. If you have healthcare access, we have, well, currently, I don't know how long this will continue to be true. But currently, if you have healthcare access, you are entitled to many preventative checks that are free. I'm thinking here like screening for cancers, adult vaccinations, things that are, very important at preventing many preventable deaths. Where I think we are doing worse than some of these comparators, these other high-income countries, these European countries, is in our public health. Here I'm thinking about how we manage risk factors. Let's take a very simple example like road safety, right? Traffic accidents. Americans have higher levels of car ownership, while most states have some legislation to wear seatbelts. Not all states do. So in New Hampshire, you are not legally required to wear a seatbelt anywhere, anyone who's sitting in the car. But even the states that do have seatbelt restrictions, they're not as restrictive as in Europe. So many states, there's no legislation for backseat passengers to wear seatbelts. And you can't get pulled over in many states just because you're not wearing a seatbelt. It's only if you were pulled over for something else. So, this is a very specific example, but it just to demonstrate that, there are these areas that, I don't think are particularly partisan in terms of public health, but that we have weaker legislation and around something that is a preventable death, that it wouldn't take a lot of money to fix, and we would see a decrease in mortality. And I think these are the areas where we see both a lot of variation across U.S. states, which is linked to variation in mortality across U.S. states, and also a lot of variation between the U.S. and other high-income countries.
Now, do you think we would have, I personally feel like, okay, seatbelt law, like that sounds like a no-brainer, like that everybody could get behind. But that our country, like it's, we have so many different belief systems and we're all about liberty and stuff. So this is something I think the whole field of public health is struggling with, right? You don't want to get branded like liberal versus conservative because it's for everybody, like public health should be. I'm just curious, like, what are your thoughts on that since,
Yeah, I do think in this area, this is the difficulty that this reaction to having paternalistic policies around public health. And unfortunately, we see that public health has become much more partisan in recent years. And I worry about what that does generally to trying to communicate these effective measures that shouldn't be so controversial to adopt if they save lives, but that people have a reaction to because we label public health as being a policy of the left and therefore, make it less likely for people to get on board.
It's a tough one.
It's a tough one. Our aim with this work is to just try to put some of the measures out there to show like these have the lack of these measures can have real implications for people's lives. And that should be more important than if we think these policies are blue or red. I'd also like to point out that in our paper where we looked at mortality across states, we see that there are good performing states that are both blue and red, and there are bad performing states that are both blue and red, and so like all states can fix and learn from each other. I don't think we need to make this partisan.
Yeah, no, I agree. I think there has to be more communication around getting more people from different politics and philosophies kind of on board. And so people don't view it as, a punishment or they're taking something away from you. Like, no, this will actually help add years to your life, assuming you want that. But yeah, I've always been curious about because the divide is so big right now. It's just, even if you say you work in public health, like you might duck in some groups because it's just seen as like this, you're trying to take my rights away or my liberties away, that kind of thing. But I do like some of these ideas that you have. I don't know about the healthcare access. I feel like every president's, it's just always an issue. It's always an issue.
Well, we've done other work looking at, the the papers we're discussing today are really kind of on the outcome side.
Yeah.
We've done a lot of work on the expenditures side too. And really, there's probably everybody has probably heard a version of the statistic that the US pays more than any other country and the outcomes are worse than most high income countries, right? And that's true, but I think those two things are related very differently in the US than they are in other countries. So what do I mean by that? I think like if we've done a lot of research on why the US spends more than other high income countries, and one of the biggest, I would say, the biggest driver of this is prices in the US. Prices in the US for health are just much, much higher than in other countries. And that's why we pay more for healthcare. And the reason we're doing worse on the outcome side is, I think has a lot to do with these public health measures. And like we said, these deaths that are, for example, external or preventable. And those are two different stories, right? But on this pricing side, I mean, health prices, we think of general prices. Affordability generally has become a much bigger issue for Americans, but health prices are even higher than I guess the price of general goods in the economy, and they grow faster. And they grow faster than they grow in other countries. And so why is this the case? Again, there's a lot of domestic work that examines this, but we have two big differences in the US relative to some of these other countries. We don't have price regulation, which we say, okay, that's fine. We have a free market that will bring down prices. But what we've been seeing over the past years is a big consolidation in the healthcare market. So when you have consolidation and you don't have price regulation, what happens is prices get higher. And so if we really, want to address, I think, some of the failures here, we need to think about how we address these problems to make care more affordable, to bring prices down or on par with other countries. And so, I think it's important to consider that if we talk about health reform and understanding, part of what is contributing to this affordability crisis.
No, absolutely. And hopefully people are working on some of these things. I wanted to ask you about the survivor effect, because I think my listeners have heard this term, and you mentioned it in your paper and how it impacted interpretation of the results. And I was just curious if you could explain, maybe break that down so our listeners kind of know what it means. And if they see it again too, they'll know what it means.
Yeah. So actually, kind of a funny story is we started this paper because we observed this effect in another paper. So we were doing another paper. We were interested in wealth-related health inequality in the US and Europe and how that changes as you retire and as you age. And so we saw that wealth-related health inequality decreased in a lot of countries in North and Western Europe and in the United States as people aged and especially in the over 70 compared to the 50 to 60. And so we were wondering, this is interesting. What is this? Is this that like somehow pensions are more redistributive, or like, can we understand what might be related to this trend? And that's kind of maybe what it looked like in Northwest Europe, where we saw that the wealth, the distribution getting a bit smaller. But what we saw in the US is that what seemed to be happening was that the poorest Americans were dying out of the sample. And so that's the survivorship effect, essentially, in a nutshell, that because life expectancy is lower and has this bigger gradient, that the poorest Americans die out at a faster rate than the Europeans.
Right, which is definitely not good. So do you think you have enough here? We always say more research is needed, right? We like every paper ends with more research is needed. It's like the safe line to end everything with. And I totally get that. But do you think like there's enough here to make policy changes, like make specific recommendations? You've obviously done more work than this paper, but you say, hey, like do this, probably we'll see some benefit.
Yeah. So I do think for more research is needed. But I also think there are some key takeaways. Now, I would say more from this body of work alone. As we were talking about earlier, I do think there are areas where we know there's large amounts of deaths annually from certain causes. Take drug overdoses, increasing alcohol-related mortality, homicide deaths, suicide. There are things that we can do in the public health system today to try to bring those numbers down. And we should take action in those areas. So that is something that I think, we can and should get started on. Where I think future work is needed is we need to better understand what drives some of the disparities that we saw. So we definitely have ideas and literature supports some of these hypotheses, but why are the wealthiest Americans dying at faster rates than most of Northwest Europeans? That we don't really know, and we can't really address that issue until we figure that out. And I think that that's important, not because it's important to look necessarily only at that cohort, but that will give us insights into some of the systemic factors that are affecting all cohorts outside of healthcare.
Yeah. Like something that's going on that their money can't really protect them from.
Exactly.
Yeah, that's really interesting. I mean, you're seeing a lot of, this is like this on social media. A lot of the wealthy people are like becoming biohackers and measuring their biological age for I always say we're in the era of I'm 99, but I have the biological age of, a 25-year-old. And of course, they're a millionaire, right? Because nobody who's worried about paying their bills is doing this. So, but those people still are going to be impacted by, the super conscious wellness person is still going to be impacted by this, whatever is causing us to have that disparity to Europe. So.
Yeah. But again, if we look at the things that they hack, right? What do? They change what they eat.
Yeah.
Right. And they spend a lot of money to afford all of the best things that are not processed and have no chemicals. And they exercise more. They have they do things to relieve their stress. So these are all clues as to what are these systemic factors in society that are killing us, and that we need to understand how we can improve for everybody and not just the ultra work.
The cold plunges. Of course, I had someone, I have to edit his podcast. He was a longevity guy, really nice guy, but and he was so focused on biology and stuff, and I'm like, okay, but how do you factor in stress and emotions into all of this? Because our society is stressful, and he was funny because he sat back and he's like, I'm not sure, because right, when you think about the stress, educational stress, and we're not very relaxed, everyone's going to work and working hard and trying to make money and all that. So I don't know.
And I think you see that stress at all levels of society.
Yes. Yes.
And there is a different, I know I see people often talk about this negatively, about, Europeans and their holidays and they're lazy, which
they're always on holiday.
Yeah. But I don't, if you look actually at the hours, they work long hours. They just have also, there's this separation between work and there's a better work-life balance. And also I think, they have a social safety net that doesn't make your work tied to everything else that makes your life secure. And one of the most interesting findings in the paper, which is actually in the appendix, was when we were trying to understand how some other determinants of health were distributed across the wealth quartiles in the US relative to our comparators. And one thing that really struck out to me was education. Higher education. So in the US, that was very, very unequally distributed. So the people in the wealthiest quartile were much more likely to have a college education, whereas in North and West Europe, it was more equally distributed. And smoking also had this, where in the US, smoking rates are lower than in a lot of these countries, but they were much more prevalent amongst the least wealthy, and in the other countries they were more distributed across the quartiles. So we see this big distribution, like this clustering of these determinants much more across your relative wealth position in the US than we do across other countries. And that speaks again to these social factors that give you equal opportunities to health, which, I think we need to explore and understand a little bit better.
Yeah, that's really a good point too about education, because I feel like college or higher education is a lot more affordable in some of these. Yeah. And over here, it's a massive stress, I even know like some of the younger ones in my family we're having this, like, do you really need college? It's so expensive, like, do you really want to go? Like, so yeah, it would be nice if everybody could afford it. That's for sure. I think that would make a difference too.
Yeah.
Well, this is really all interesting stuff. I mean, certainly the time is right for it to consider all these things, and whatever the new public health system that emerges, I guess we're all sort of finding out, as they go along. Hopefully everybody can find a space and a role and work together, somehow still keep moving forward. I don't know. I'm staying positive, I'm choosing positivity. And,
I think that, if anything, we're trying to reduce the stress. So
exactly. Yeah. I think today in the contracting world, they were announcing like huge cuts. So that's what I'm in. So I'm like, gosh, I don't know. I guess I'll check after this podcast, and then I'll go for a run. But this is all great stuff. Are you doing more research in this area? Oh, you are?
Yeah, we have a lot. Actually, we're exploring some of the things we're talking about, these policy differences, both across the states and how the U.S. compares to other countries, to try to find these public health areas where we can, make better change policies that can have potentially.
Yeah.
And we're also trying to understand, trying to focus on areas that hopefully are not too partisan, and try to make a case for depoliticizing kind of public health. So some work on that.
That's where it's at. That is where it's at right now. I mean, if you could figure that out and build that bridge, because right now it's just so, tribal. So I'm just, even from scientific communications, and I think it all starts too, like on a very basic level, like you care about like these people, we care about each other. It's like, it starts there, it's not like a punishment. It's like, no, like we care about you. Like and we care about what you care about too. I think it has to start there on some very basic level,
Yeah. Yeah. So. Well, we all want to make sure that everybody has the opportunity for longevity, right? So
yeah. It can't be about punishment and yeah. Don't you want to live longer? Yeah, I'm always curious. That's where the art of connecting comes in, I think. And people in public health can do better at that, not like isolating so much. I think that's important too. But yeah. So definitely stay in touch. I'm curious as to what you find in the different policies and that kind of thing. I'm going to go read about seatbelt laws and and texting. Like texting was right. Like don't drive. I feel like every state should have that. That's like a no-brainer.
Yeah, right? That's another one to look into. I mean, there are so many of these things where, and if you add them up, and that's what we're trying to do. They seem like small policies, but if you take them as a whole, do you see patterns? And I'm also really interested in some of these, like in our other paper where we looked at states specifically, we saw that there are certain states like Utah and Idaho that do very well. And I'm like, well, why? And they spend less. Like, so how are they doing it? How do they have these
Utah
lower rates of avoidable mortality? And then you've got other states like Massachusetts that has very good treatable mortality, even though it's very expensive. So like trying to take these positive outliers in terms of the outcomes and like look at what they're doing. I think there's got to be some lessons there, and that states can learn from one another. And
Yeah, yeah. And what some states do well, and some states could do better at. That's really interesting stuff. So
Mhm.
I look forward to seeing what else you produce. I know New York City should have a law. I do this too, though, because I look at my phone. I almost walked into a bus. Like he
Oh,
saw
no,
me,
yeah.
like, and I'm like this walking, and I'm like, oh my gosh, imagine if that is my obituary. Like, don't let it be, Aaron, but it could be.
Yeah, yeah, no, I guess it
I
only where it exists. It only exists when you're driving, not when you're walking. So,
Yeah, exactly. I know. I mean, that
yeah.
would that would get me some kind of Darwin award. I mean, for sure. So, but thanks for your time today. I'm glad we got to chat about this and stay in touch.
Yeah, and
Yeah,
I can send you the other article too with the states.
definitely. I like to do that. I share the links in case any of my listeners are nerdier, which is a good thing. I think I don't want to read the paper. So,
Great.
all right. Enjoy the rest of your day there. Thanks for your time
Thank
today.
you. Have
Okay.
a nice weekend.
You too. Bye.
Bye.
All right. Thank you, everyone, for listening to this episode of the Causes or Cures podcast. If you liked what you heard, please take a moment to subscribe, leave a review, and share the podcast with your friends. If you didn't like this episode for some reason, check out some of the other episodes. Maybe there's something there that will strike your fancy. Uh, um, Anyhow, if you leave a review or a rating, it does help the podcast grow and, get ranked in whatever those things are that podcasts get ranked in, all that marketing stuff. So, but, if you like it, if you don't like it, sorry, there's other podcasts out there. Okay. And now it's time for the closing quote. And this is a good one. This one is from Orson Welles. My doctor told me to stop having intimate dinners for 4. Unless there are 3 other people. Ha ha. That's good advice for all of us out there, isn't it? But seriously, I went out for dinner recently and I don't do this a lot. I cook a lot. Simple stuff, simple healthy stuff. I know what I'm eating. I like doing it. Cooking is like meditative for me. I'm not like a great cook, but simple healthy stuff. But when I went out to eat at a restaurant in New York City, I was blown away by the size of the portion they brought me. And I'm like, oh my God, that could feed like 5 of me. But at the same time, one of me could eat it if I, just kept it in front of me and kept eating like on autopilot, which is something to watch out for, you guys. Like when you go out to eat and they put something in front of you, it doesn't mean you have to eat the whole thing. You can ask for a doggy bag. I always do. And it's like, who cares? Some people are like, oh my God, this is a fancy restaurant. Don't ask for a doggy bag. Screw that. Ask for the doggy bag. Don't waste food. Take it home. Food, everything is expensive out there. And you know what? You'll have a meal for like the next day, maybe, maybe like the next 2 days. I don't know. All right. That was a tangent, but good for us. All right. I hope you tune in next time and goodbye for now.